should make you kind of happy. Sensory pathways and somatic nervous system. When I say somatic, what do you think of? Skeletal? Muscle. Alright. Alright, so sense organs. I want you to think of sensory receptors that enable the body to respond to stimuli caused by changes in the internal or external environment. Okay, internal or external environment. I want you to know that there's two categories of sense organs. There's general and there's special. So you want to highlight that in your notes real big. General and special. General is skeletal muscle, somatic. General sense organs consist of microscopic receptors widely distributed throughout the body. We find these in skin, a mucosa, connective tissue, muscles, and even in some viscera. Special sense organs are grouped into localized areas, for example, the nasal mucosa or the tongue, or into more complex organs such as the eye and ear. So some of this we've already talked about when we talked about reflexes. Remember the 3 neuron reflex are, so if you touch a hot stove and you leave it away, that's a reflex. So receptors respond to stimuli by converting them into nerve impulses. And what are nerve impulses? Starts with an A. Action potentials. Nerve impulses are action potentials. So, receptor potential. Local potential, this is what I just went over, that develops in the receptor's membrane when an adequate stimulus acts on the receptor. Okay, remember, to have an action potential, we have to have a local potential first. The impulses, which are the action potentials, travel over the sensory pathways to the brain and spinal cord. I want you to highlight adaptation. Adaptation. Decrease in receptor potential over time in response to a continuous stimulus. Okay, what does that mean? Tell me in layman's terms what that sentence means. You get used to it over time. Okay, that is so important. What condition does this not always happen? Adaptation, where the patient does not adapt over time to certain stimuli.
Happens a lot in children.
Well, autism, right? Autism. You know, do you hear the humming of the projector?
Yes.
Okay. You know, when I first turn it on, it's really tough. But then you get used to it, right? That's adaptation. Over time, you get used to it. You're able to kind of block it out. Well, in certain conditions with autism, they can't. So they are responding to stimuli all around them all the time. You know, and that's the really severe cases. I mean, can you imagine responding to every single smell and sound around you all the time? Who said yes? That's tough, right? That is really tough. How do you guys study? Do you study in like a really quiet room, or do you study with noise? Do you study with music?
Music. Background noise.
Yeah, that background noise?
Has to be quiet.
Has to be quiet. Okay. So if somebody, if you were studying, and let's say that we were over here and we were talking, would that would bother you?
It doesn't completely bother me, but yes, like I find myself like hearing that and my brain doesn't like focus. So whenever we're chatting and stuff, like we study and I'm like, I have to like,
You have to
try to like really
Yeah.
tune into what I'm reading.
So I was just like you when I was in high school, and my undergrad work, I had to have complete silence, right? Then when I got to medical school, I realized that was never going to happen. So I just learned to block everything out. They could be having a conversation about the world coming to an end, and I just stayed focused until they said my name. And then it was, you know.
I've gotten a lot better, but
So
it
what-
was pretty bad for a while.
Yeah, I know what you mean. So what they say you should do is study in an environment that is closest to where you're going to take your exam. So for instance, I used to always study standing up, so I would just walk around and read my text and, read the notes, and then I thought, well, that's kind of stupid. Because if I'm taking the exam, I just can't get up and walk around the classroom. So, I started studying differently. But they really say that you should try to study in an area that is very similar to where you're taking the test. So, okay, let's see. Different types of receptors respond to different stimuli. So when a threshold is reached in the receptor potential, an action potential in the sensory's neuron's axon is triggered. So when the membrane is at rest, do you remember what the millivolts are? Negative 70 millivolts. But if we're having an action potential, it's going to be at least what? It's at least going to be negative 50. Okay, at least. When the action potentials reach the brain and spinal cord, they either are interpreted as a particular sensation, such as hot or cold, or they initiate a reflex action, such as jerking your hand away from a hot stove. Although we may have no conscious perception of certain sensory inputs, they often play a critical role in maintaining homeostasis. So, and again, examples might include our ability to sense and respond to changing levels of blood glucose and carbon dioxide, even though we're not aware of it. Okay. So, I do want you to know slide 6. So, in the presence of a continuous stimulus, the rate or frequency of impulses declines quickly in rapidly adapting receptors of the skin. Okay, so your key words are going to be decline quickly in rapidly adapting receptors of the skin. Now it's different for muscles. Look at muscles. In slow adapting joint and muscle receptors, the rate of impulses instead declines gradually and levels off to a constant, moderately high level. Why is that? If it didn't do that, what would happen to our muscles? Yeah, well, and they would cramp all the time, right, before the atrophy took place. Right? So they have to, for muscles, they have to be slow adapting, and the rate of impulses declines gradually. Thus, information about body position is continually sent to the central nervous system. Okay, distribution of receptors. So we have receptors for special senses, for smell, taste, vision, hearing, equilibrium. They are all grouped into localized areas or complex organs. General sense organs or somatic senses are microscopic receptors, and they're found throughout the body. So sensations produced by the receptors of general sense organs are often called somatic senses. The distribution of general sense receptors is not uniform in some areas, and we've already learned this. So if I take, excuse me, please. If I take a sharp object and I poke my finger, okay, I know exactly where I'm touching, okay? But if I do the same thing, say, to the skin on my back, I may not feel it as intense, okay? And that's because the receptors on my back are not as dense, okay? They're more sparse. We've already went over skin from last semester, but I'm gonna refresh your memory a little bit. So at the very top, we have what layer of skin? Yeah, the epidermis. And look at all these free nerve endings. Okay, we have tons and tons of these free nerve endings. And that's what allows us to do what? What did we learn about skin last semester? And it is our first line of defense, right? But what else does it allow us to do? Feel what? Pain. Temperature, big time, right? It plays a big part in temperature regulation because the skin is the first to detect hot and cold, right? Okay. Exteroceptors, I want you to know, you want to highlight that real big. Exteroceptors on or near body surface. On or near body surface. They're often called cutaneous receptors. What does cutaneous mean? Skin. You got it, skin. So it's easy to remember. Exteroceptors on or near body surface. Visceroreceptors tells you, what's visceral? What's visceral mean? Organs. So that tells you they're going to be located internally, often within body organs, viscera. So visceroreceptors are going to provide the body with information about the internal environment. So what does that mean?
The organ function for vision.
Exactly, very good. So like, if you have a kidney infection, for instance, okay, where might you feel the pain? Yeah, in the lower back, right? In the lower back. So I want you to know slide 11. So examples of exteroreceptors include those that detect pressure, touch, pain, and temperature. Remember, we're talking about cutaneous. So that all makes sense. Pressure, touch, pain, and temperature. For visceroceptors, we're talking about also pressure, but more stretch, chemical changes, hunger, and thirst. We're thinking more internally. We okay so far? Okay. So on slide 12, remember, I believe I mentioned it last week. What is proprioception? Do you remember proprioception? It's our ability to know where our body parts are without seeing. Okay, so if I were to turn the lights out in here and was completely black, you couldn't see anything, you would still know that you were sitting, right? If you stood up and were standing, you would know that you were standing, even though you can't see a thing, okay? That is proprioception. I'm gonna add to that now because there's two different types. So proprioceptors is a special type of visceral receptor, location limited to skeletal muscle, joint capsules, and tendons. It provides information on body movement, orientation in space, and muscle stretch. Okay? So I want you to know there's two types of proprioception. There's tonic receptors and there's phasic receptors. Okay? So tonic receptors generate action potentials as long as the stimuli are applied and accommodate or adapt slowly to locate the position of your body parts. So if you're standing still, okay, and you can't see anything, and you're not moving any part of your body, that is tonic receptors, because you still know you're standing. If you're sitting, not moving, just sitting, that's the tonic receptors that are generating action potentials, and they're going to be able, the stimuli will still be applied, and it's going to accommodate and adapt slowly to locate the position of your body parts, because your body parts aren't moving, right? Phasic receptors accommodate rapidly. So here's your key word for phasic, rapidly. Tonic, it's going to be slowly. So phasic receptors accommodate rapidly and sense only when there is a change, like in moving body parts, okay? So if you're sitting and you raise your hand up in the air, well, now that's phasic receptors that are sensing the change, and they're going to accommodate rapidly, right? Because you're moving body parts. That make sense? You know how I remember this in medical school, and I probably shouldn't tell you this, but, so gin and tonic, I used to think, okay, gin and tonic, when I drink a gin and tonic, I'm just sitting there relaxed with my gin and tonic. So it let me remember that I'm relaxed, okay, no moving parts. Okay? Are we okay so far? So the firing of non-adapting tonic proprioceptors allows us to locate, for example, our arm, hand, or foot at rest without having to look. Now, I know you're thinking, well, this is so stupid. Of course I know I'm sitting. Of course I know I'm standing. But there are pathologies where the patient doesn't know if they're standing or sitting. Okay, so we take it for granted. So phasic proprioceptors are rapidly adapting receptors, so they are triggered only when there is a change in position. Phasic proprioceptors therefore permit us to feel the changing position of our body parts during continuous movement. So let's say that this is affected. Let's say we have a patient and these phasic proprioceptors aren't working anymore, or they're compromised. How are they going to be walking? Yeah, which is, what do you think of with that? What kind of disease or disorders? MS is a big one, right? So we take all this for granted. Classification of receptors by stimulus. I want you to know all of these. Okay, now some of them are easy, like thermoreceptors, you know by the name what's it dealing with. The temperature, right? So that's an easy one. We have mechanoreceptors, chemoreceptors, nociceptors. I want you to always think of pain. Pain, lots of pain. Photoreceptors are easy because light, and we only have photoreceptors where? In the eyes. And osmoreceptors. Okay, so let's look at each one. And you want to know slide 15 really well. Mechanoreceptors are activated when deformed to generate a receptor potential. So what do I mean by deformed? So a mechanoreceptor is a sensory receptor that responds to mechanical pressure or distortion. Okay, that's a mechanoreceptor. Chemoreceptors, I want you to think of, they're activated by the amount or changing concentration of certain chemicals, such as taste and smell. So if I bring out the cats, your chemoreceptors are going to be activated, right? Because of the smell. Thermoreceptors are activated by changes in temperature. Nociceptors are activated by intense stimuli that may damage tissue. The sensation produced, of course, is pain. Photoreceptors are easy. They're only found in the eyes. They respond to light stimuli if the intensity is great enough to generate a receptor potential. And osmoreceptors, I want you to really know this, it's concentrated in the hypothalamus. Of course they are, right? Because the hypothalamus does everything. And are activated by changes in the concentration of electrolytes in extracellular fluid. It stimulates the thirst center. Stimulates the thirst center. Who's that? Yes, osmosis. Do you remember? Good. I'm going to add more things to this hypothalamus. It does so much, lots of functions. Okay, those three nerve endings that I showed you, most widely distributed sensory receptor, you want to know that. Three nerve endings are the most widely distributed sensory receptor. So pain sensations, I want you to know that tactile sensations, I want you to think of skin movement, itch, tickle, and discriminative touch. What does discriminative touch mean? No. Discriminative is where you know exactly where it's touching you. Okay, discriminative, you know exactly where it's touching you. Discriminative touch. Crude touch is where you know something has touched you, but you're not sure quite where. Okay. So classification by structure divides sensory receptors into two groups. Those with free nerve endings and those with encapsulated nerve endings. Receptors with free nerve endings include exteroceptors and visceroceptors. So this part right here, I want you to know really well what I'm going to say next. Nerve fibers that carry pain impulses are either acute or chronic. They're either acute or chronic. If they're acute, we refer to them as fast A pain receptors. Okay, if they are acute, we refer to them as FAS A pain fibers. And they're going to transmit a sharp, intense, localized pain. Okay, I want you to know that. Acute, you know, it's kind of easy in a sense, it starts with an A, and they're known as A pain fibers, right? They're fast. Your chronic is going to be slow, B fibers, and they are going to transmit a less intense but a more persistent dull or aching pain. That's why when you go to the doctor with some type of pain, the first thing they ask you, is it acute or chronic? Right? So they're asking you, basically, when did it start? You know, if you say, you know, hey, it started a few hours ago. It's very intense, it's localized, so that's going to be acute. If they tell you, oh, you know, I've been suffering with it for months, okay, it's like it's not intense, but it's always there, it's like a dull, aching pain. Okay, that's chronic. Free nerve endings are also the primary receptors for hot and cold, as we talked about. Yeah. Okay, cutaneous sensations. So for you as nurses, one of the things you're going to be seeing a lot of, and we've talked about this, is diabetic neuropathy. Okay. As the disease progresses, they start losing feeling in their hands and feet, mostly feet. So we have this little instrument here that we use, and what are they doing here? They're testing to see if they have, sensation, if they have feeling, right? So for a diabetic patient, the protocol is they come in once every 3 months. I don't agree with that, I don't do it in my practice. But that's the protocol, not just here in New Mexico, it's all over in the United States. So every 3 months they come in, they're supposed to have their feet checked, you're gonna check their toenails, you know, make sure they're all okay, make sure there's no sores on their feet. What else do they do with this diabetic check besides feet? What else do they do?
Eyes.
Well, they're gonna send them to an eye doctor, right? They should do that yearly. They should be seeing a nephrologist yearly.
And every 90 days is A1C?
Yes, they do the A1C, they do blood work, right? What is wrong though with waiting 3 months in between? They give all the medications, so whatever the patient's taking, they refill all the meds.
Checking in to see if there's compliance.
Yeah, you know, especially when they're really, really bad, they should be seen, in my opinion, at least bi-weekly. You know, I see my patients once a week though, because I want to be on top of it. Here, what's happened here?
Direction.
Well, they stepped on something, so they have a foreign object in their toe. Probably didn't even know it, because they can't feel anything. And that's really bad, especially when you have a patient that has diabetes, or they have vascular issues. You know, could lead to amputation, probably would. If I'm your new patient and I've been diagnosed with diabetes, what are you gonna tell me about foot care? You know, I know nothing about it.
Check your feet nightly.
Good, yeah, all the time,
Try your
right?
shoes.
No, what if I tell you, you know, I can't see my feet?
Use a mirror.
Use a mirror, but, and that's good, you said that so matter-of-factly, but sometimes patients don't know that, right? Especially if they live by themselves, okay? What am I looking for?
Anything normal.
Yeah, any redness, right? Ingrown toenails, you want to explain to the patient how devastating an ingrown toenail could be to a diabetic patient. They could lose their toe, right? What else? They should never, ever do what? Walk barefoot. Never, ever, ever, ever. And they all want to.
Yeah.
But never, ever should they walk barefoot. They should never use those foot baths. Why? They can't feel temperature. So they could suffer a severe burn. So things like that, you want to make sure. We can't assume that our patients know these things, right? We have to educate, we have to tell them. And sometimes you have to tell them more than once, right? Okay, sense of touch. What do I want you to know here? Tactile or Meissner corpuscles. I do want you to know about those. They're large numbers in hairless skin areas. So we really only see them in areas where there's no skin, like nipples, fingertips, and lips. I want you to know that. Question. Pacinian corpuscles are found deep in the dermis. I want you to know that. And joint capsules, so you want to know where they're found. They adapt quickly, but sensations they evoke seldom last long. Okay, so you want to know slide 20. And you want to know the textbook definition of proprioception. It's the ability to sense stimuli arising within the body regarding position, motion, and equilibrium. Even if the person's blindfolded, he or she knows through proprioception if the arm is above the head or hanging by the side of the body. The sense of proprioception is disturbed in many neurological disorders. And these last two slides, I just wanted to give you an idea about referred pain regarding organs. Okay. So if someone is suffering from lung and diaphragm issues, they could feel discomfort here. The heart, obviously in the chest and the arm, but also, and this is more for women than men, but pain right here in the middle of the back, in the upper back. They have jaw pain as well. What else? Pancreas. They have pancreas. The referred pain is usually here and here on the side of the back, or I'm sorry, on the lower than the middle of the back. Pancreas. We're going to talk about the pancreas and the pain or the symptoms. The patient usually, they don't have any until it's stage 4. Kidney, look at the kidneys. They can have pain here on the side, of course lower back. So referred pain is important when we're diagnosing different illnesses. If we know just a little bit about these maps for referred pain, sometimes we can diagnose, you know. Organ pain is tough because it is internal, and it's not like we can, you know, it's not like something that's external where we can actually see it right away. So, okay, any questions at all? I also want you to know we have referred nerve pain as well. Okay, you know, you can have a pinched nerve in the neck and maybe not even have pain in the neck, but you're going to have it in your hands or fingers or. And I just want you to always remember that our patients, I don't think any of us are textbook perfect, right? I mean, I think I told you, I had a patient one time that she had chronic kidney infections for years. And you know what her symptom was? She was vomiting. That's not even a symptom. But she would vomit and she'd call me and she'd say, I have a kidney infection. Well, the first time she did it, I thought, well, no, you don't. You know, you're just sick. I mean, I didn't say that to her, but that's what I was thinking. And sure enough, she had a kidney infection, and every time she threw up, it was a kidney infection. So everybody is different. Okay, any questions on this at all? I told you this is a very, very long chapter. Nothing? No? You gonna be ready for your exam Thursday? You're gonna do really well, right? So I can have a nice Christmas. Yes? That'll be a big Christmas present if you do well on this exam. Do you have anything for micro this week?
We have a quiz tomorrow.
Oh, just a quiz?
Yeah.
Just a quiz. All right, guys, you wanna start the lab early? Yeah. You wanna start at 20 after?
Yeah.
Is that too early or is that okay?
Fine.
Okay, all right, I'll see you there at 20 after.
Well,